right? So when it comes to your toddlers, I mean your infants, it's a good idea to sometimes use a tongue depressor when you put in an OPA. So with the pediatric, especially an infant, we definitely do not want to put in an OPA upside down as we would with a normal adult. And the reason is because their tissue is much more sensitive and fragile. So we can actually cause bleeding in the mouth, and we definitely don't want to do that. So what we do instead is we get a tongue depressor, depress the tongue downward, and just put in the OPA as you see here, just go straight back. But of course, this depressor will be pushing down on the tongue, so it can slide in there easily. Uh, as far as nasopharyngeal airway adjunct, there really is no there's not a big difference as far as placement, as far as I know. It still goes ideally in the right nostril, and then you just push all the way back. See, identified type, partial obstruction. So clearing an airway obstruction. Identified type. Is it a partial obstruction or a complete obstruction? If it is a partial obstruction, we always want to, well, it depends on how old the child is, but if the child is older, like a high school student, for example, we can try to have them cough it out, just kind of walk them through it and then just talk them through coughing it out. And then if it's a baby, that's what we do. If it's an actual baby infant, we tap the baby on the back of the shoulders 5 times. And we actually went over this the first 2 days of the class for CPR. I'm not sure if some of you guys remember or not, but we actually covered this. And what you want to do is you want to slap behind the baby's back, the shoulder blades 5 times downward. Then you want to flip them on their other side, on their back side, and do 5 compressions. So it's 5 and 5, 5 and 5 until the obstruction comes out. For complete obstructions, obviously, we're going to, for an adult or a high school student, we're going to do the Heimlich. And for your infants or smaller toddlers, this is what we're going to be doing for them, okay? And then your chest compressions would be just as if you were doing CPR, but instead you're only doing 5 compressions, 1 second each. And you're going back and forth between this and this, this and this, okay? Now, if your pediatric, your infant patient becomes unconscious, they pass out because they've been choking on the object for too long, then we just do this. We just put them on a flat top, on a hard flat top surface, and we do CPR, where you're doing 30 compressions and 2 breaths, 30 compressions and 2 breaths. But that's after they passed out from us doing this and this not working. See, high concentration. See, providing supplemental oxygen and ventilations. High concentration oxygen should be administered in children in respiratory distress, those with inadequate respirations, and possible shock. See, young children are often afraid of an oxygen mask. So that's why we do blow-by for them sometimes. We'll just do a blow-by. Or another thing you can do, like it says here, is just get the tubing. So you would get this tubing and put it through the bottom of a cup and have that as blow-by. Or the other option is just to get the non-rebreather mask, which is what I would do, and use that as blow-by, or NRB mask preferable. And that's usually what we go to, is that. The only time that I would go to a cup is if for some reason, if they don't want the mask, not even as blow-by, but a cup would seem more familiar, so I can see why I would go to that. That's when I would go to a cup, if the non-rebreather did not work for the pediatric. See, guidelines: breathing too hard through the pocket mask, or using excessive back pressure and volume. So if we breathe in too much when we're giving a patient a respiration, or if we squeeze too hard on that bag, what's happening is that we're giving excessive air. We're giving too much air. And so after the lungs fill up, that air is going to backtrack and go into the stomach. Or if you do it too much, especially for an infant, there is the possibility of blowing out a lung, and that's not good. So You always want to give 1 second, one breath over 1 second each, and always let go of the bag as soon as you see chest rise, okay? That means when you see chest rise, that means that the patient has got enough air in them, and you can go ahead and let go of the bag and get ready for the next ventilation. And of course, there are different kinds of masks that go on the BVM, and they range in, I think, at least 3 different sizes. You have your infant size, your child size, and your adult size. So make sure it measures up, because if it doesn't measure up and it's too big, air is gonna leak out to the sides and it's not gonna be effective. Caring for shock. Common causes of shock in infants. Diarrhea. This would lead to diarrhea and vomiting would lead to a hypovolemic shock. That means low volume. Infection. This is more of would be on the side of septic. So sepsis could because that causes vasodilation throughout the body. Trauma obviously would be bleeding out, possibly a blood loss, go hand in hand kind of. Allergic reaction, we're talking about anaphylaxis. So with an allergic reaction, we have the same issue as with an infection, with the system, with the body-wide infection, that's sepsis. So sepsis and anaphylactic shock will both create vasodilation, which brings the blood pressure down. Poisoning, just a whole bunch of different kinds, and cardiac events, which are rare for infants. Usually, when it's medical for infants, it's going to be respiratory. When we think cardiac is usually more of an adult issue, usually, but there are exceptions, obviously. See, protecting against hypothermia. Now we talked about why kids are more susceptible to hypothermia, and it's because they have more outside. They have more. The container's bigger as opposed to what's inside, so they have more skin in comparison to the content inside the actual body. So because of that, there's more space for heat to escape from. Cover patient's head and body. Keep the patient compartment warm. Avoid rough handling. Consult medical control. So just some things you can do to keep the patient warm. See, pediatric medical emergencies. What do we have here? See, likeliest cause of cardiac arrest in. Okay, so a respiratory disorder is the likeliest cause of cardiac arrest. So for infants, so for children, they tend to go into cardiac arrest secondary to respiratory arrest or some kind of respiratory issue. And that's what this is saying. Distinguish whether probable cause is upper or lower airway obstructions. By now, you guys should know the different kinds of sounds and should also have an idea of where it's coming from. Care for upper airway obstruction, not indicated for lower airway disorder. Critical to alert. See, difficulty breathing. So number of diseases or disorders ranging from less serious. A cold is less serious to epiglottitis. So epiglottitis means that the epiglottis, the little valve that hovers over the trachea, that means that it swelled up. Itis means swelling. So this right here means inflammation. So it means that the epiglottis is swollen. And if it's swollen, it's gonna obstruct air from going into the trachea because it's right above the trachea. So that's why that's more of a serious issue. See, the role of EMT is to recognize signs early in respiratory distress and treat it. See, difficulty breathing, differentiating upper airway problems from lower airway problems. See, so upper airway problems, of course, upper airway, so it's gonna affect the mouth and the throat. So the biggest issues we have up here is gonna be usually one of two. It's an actual physical obstruction, a physical object, or is going to be swelling. That's usually the biggest issues. Like it says here, foreign body obstruction, trauma, swelling, and from burns or infection. So that's the issue with the top, obstruction or swelling. Lower airway, usually it's going to be a muscular issue. And why I'm saying muscular issue is because I'm talking about the muscles that line the inside of the airway. So the inside, the little tubes, the bronchioles, you have muscle, smooth muscle. And when they spasm or swell up, that's what causes that wheezing sound. So asthma is a spasming of the bronchial muscles. So when you get